fragmentation of COVID-19 really forced the private healthcare industry to band together and to collaborate far more than it had done previously. And especially in a system, in an era of healthcare where there is mutual distrust amongst many of the role players within our private healthcare industry. COVID-19 really helped to assist in dissipating some of that. However, it still does exist. So let's quickly just look at some basic economics when we look at it on a global scale. The 2 years into the Sustainable Development Goals era, where global spending on healthcare continues to rise. It was 7.8 trillion US dollars in 2017, or about 10% of the global GDP, and 1,080 per capita, which was up from 7 trillion in 2016. The health sector continues to expand faster than the economy. Between 2000 and 2017, global health spending in real terms grew by 3.9% a year, while the economy only grew by 3%. And as the healthcare sector grew, it also became less reliant on out-of-pocket spending. So your total out-of-pocket spending more than doubled in low and middle income countries from 2000 to 2017 and increased by 46% in high income countries. So now when we talk about out-of-pocket spending, this is in terms of your WHO definition, what I'm going to talk about. And out-of-pocket spending is described as payment by households directly to providers to obtain services and health products. It includes purely private transactions, individual payments to private doctors and pharmacies, official payment, patient cost sharing, user fees, co-payments within defined public or private benefit packages, and informal payments. Thus, out-of-pocket spending can occur as an explicit part of policy or simply through market transactions, meaning in terms of our medical aid industry or in terms of our private healthcare industry through any type of out-of-pocket payment, any type of levy, or even the fact that certain healthcare providers do not take medical aids and they take cash up front. So now let's just actually look at how much are countries spending as per their incomes. And you'll see that the richer countries actually spend more in healthcare. But there are large variations among countries of similar incomes. So if we just concentrate here on the continent, you'll see that we're spending far less on healthcare per person. However, if we look at South Africa, you'll see that we're spending about 200 to 499 US dollars per person on healthcare. Now, this includes both public and private spend. Now, we've also noticed that in the past couple of years, and especially if you see these statistics from 2017, donor funding has actually decreased. So you'll see public spend globally is sitting at 4.7 trillion and private expenditure at 3.1 trillion. So now what I have done is I have included the spend for lower middle income and upper middle income countries because South Africa is classified as a lower to upper middle income country. So you'll see that our out-of-pocket spend, which is considered part of our private healthcare spend, sits around 40% to 31%. So now what's happening in our ecosystem as a country when we zoom in? We saw that our GDP growth fell by over 50% in the second quarter of 2020 during the COVID-19 lockdown. There's shrinking health budgets within the public sector. As I'm sure we've all noticed that there were serious cuts to the budget in public sector. We have higher premiums in the private sector, especially let's zoom in on medical aids, where you're looking at an average increase of 10.7% for 2025 across your largest 12 schemes, and some schemes reaching highs of over 13%. And as we have now, we are on the pathway of an unsustainable private healthcare system. For example, with the collapse of Health Squared Medical Scheme, which just happened in 2022. What are some of the other challenges that we're facing? In general, across the entire system, we're looking at lack of access to healthcare, costs of medical treatments, shortage of medical staff, be it in public or private, healthcare costs outstripping inflation. So in 2023, your healthcare CPI was 10%, while normal standard CPI was sitting at about 4%. So it is year on year higher, which means that healthcare is year on year higher. It has higher inflation, number one. Number two, people's salaries just can't keep up either. We have non-communicable diseases becoming a leading cause of death worldwide, with the WHO and certain sources quoting at 71% of deaths worldwide can be attributed to NCDs. We have increasing longevity of our citizens. The last statistics, I believe, I stand to be corrected, for life expectancy in South Africa had increased to about 64 years. We have a transition right now from a hospice-centric private healthcare system to a primary healthcare system. However, we are still hospice-centric heavy, which means that majority of the population in private healthcare still gets their treatment in hospital. And we have significant loss to FWA, which is fraud, waste, and abuse. On average, South Africa loses between 22 billion to 28 billion annually just to fraud, waste, and abuse alone, which then places a significant burdens on the medical aid schemes, which then that filters down into our premium increases and contribution increases, which is why at times you'll see contribution increases sitting at 10%, 11%, 12, and 14. Now, from the latest CMS industry report, which has just recently come out, despite all of this, we have seen a growth in the number of beneficiaries rise from 9.39 million to just over 9.1 million. However, the proportion of beneficiaries covered by medical schemes relative to the national population declined from 16% in 2000 to 14% in 2023. You'll also see that as of 2023, the total number of medical schemes decreased to 71. So in 2020, we started at about 144 schemes. And over the years, either through amalgamations, liquidations, or collapse of medical schemes, we're now only left with 71 schemes, with 16 open schemes and 55 restricted schemes. If we just look at the distribution of beneficiaries in the province, once again, we'll see that the highest concentrations are in Gauteng, Western Cape, KZN, and ironically, only 2% of the population in Northern Cape is covered by medical aid. Now, let's look at the health market inquiry, which was actually quite pivotal in our private healthcare sector. So on the 29th of November 2013, the Competition Commission took a decision to initiate a market inquiry into the state of competition in the private healthcare sector, also infamously known as the HMI. Following this decision, the Commission published the terms of reference as required through the Act, and the final findings and recommendations were released in 2019. Many of these findings and recommendations are actually still relevant today and have not necessarily been implemented across all spheres of private healthcare industry and within government in terms of regulations and regulating of the private healthcare industry. So what are some of the key findings? The South African private healthcare market, we found that it is characterized by high and rising costs of healthcare and medical scheme cover and significant overutilization without stakeholders having been able to demonstrate associated improvements in health outcomes. A more competitive private healthcare market will translate into lower costs and prices, more value for money for consumers, and should promote innovation in the delivery and funding of healthcare. Competition should occur on price, cost, and quality, and not on risk avoidance. Innovative business models, however, were almost absent and were reported to be obstructed by funders and by some practitioner associations and limited by the rules of the HPCSA, both facilities and healthcare professionals. So this was actually the findings in 2019, especially the last point, which is quite relevant, quite important. You have found that subsequently, the HPCSA has amended its ethical rules to accommodate for what we call multidisciplinary teams, which I'll get into. If we now move on to what exactly are these funding models, you'll find that the current move in the private healthcare sector is a move away from fee-for-service to alternative reimbursement models, or as we know as ARMs. And providers being incentivized for improved clinical outcomes, which is also known as pay for performance. So instead of a patient comes in, I go into my GP, I say to my GP, I'm sick. And then I get billed then and there for a consultation, probably an injection, goodness forbid, needles or whatever, right? That is your traditional fee-for-service model. However, we now have alternative reimbursement models. And there has been an introduction of what's called pay for performance. Now, pay for performance payments are adjusted to payment that providers receive for reaching certain quality benchmarks or other performance measures. For example, an example of a performance benchmark would be you have 20 patients within your practice as a GP. All those 20 patients that have been risk stratified, you will be paid higher for performance if you are able to maintain that 60% of your patients are stable diabetics. They are controlled diabetics. You do not have uncontrolled diabetics. Also, you might have a pay for performance incentive for patients with decreased rates of complications. So for example, how many patients eventually develop diabetic retinopathy? How many patient visits do you ensure that your patients see the podiatrist? What are your readmission rates? How many specialist visits do you have within your population group of those patients that you have within your GP practice? In terms of specialist care, if you maybe look at a popular model that we have now that I'll be discussing, which is for arthroplasty, on the performance of your arthroplasty as an orthopedic surgeon, how many revisions do you have within your population and operations that you do? What is your average length of stay for your patients? How many readmissions do you have? What is your rate of sepsis or post-surgical infections? So these are the type of metrics that are looked at in terms of what type of ARM do providers enter into with the funders. So these ARMs can take the form of value-based care models, global fees, or bundled payments, and public-private partnerships. So the value-based care models I will touch on. In terms of your global fees, you'll find that a very common global fee is your bariatric surgery for those schemes that pay for it. And it's one bundled fee where that fee will include your hospital admission, all of your specialists and your allied health providers included as part of the treatment of this patient. It will include the anesthetist and certain follow-up visits, if included, in one amount. Let's say that amount is 200,000. Within that 200,000, all of you must distribute that 200,000 between yourselves and pay for your hospital admission. Now, that type of arrangement is not necessarily based on a pay for performance. Or you could have a global fee where for your entire joint replacement, it is one global fee, which includes the joint prosthesis, it includes your anesthetist, your orthopedic surgeon, your admission to the hospital. And then on top of that, depending on your clinical outcomes, you can have a pay for performance amount linked to that. So you can have various models within these ARMs and within your innovative funding models. So you can mix and match them, and it doesn't have to be a pure single type of model that you can have. And you have models that actually span from outpatient settings to hospital settings, which we can discuss. So what are the components of a funding model, of one of these models? Number one, on the patient side, you're looking at lower costs and better outcomes. So if I am able, so let's say a medical aid gives you 150,000. And with that 150,000, you are able to deliver better patient clinical outcomes than a fee for service that is charging 200,000. You are saving on costs, you have healthier patients, and in certain funding models, those costs could come then back to providers depending on how well they have met their performance. In terms of your healthcare providers, you're looking at higher patient satisfaction rates and better care efficiencies. From the funder side, stronger cost controls and reduced risks. When it comes to risks, what they're talking about is improving in your downstream costs. Therefore, if you treat the patient at the right point in time with the right healthcare provider at the right level of care, you are then able to minimize your risks of further complications, readmissions, and poor quality of life for patients. For suppliers, we're looking at alignment of prices with patient outcomes. Suppliers being like your hospital groups, like clinics. Excuse me. And for society, you're looking at reduced healthcare spending and just a better overall health. So let me explain a very famous model that has been made, that is from Michael E. Porter and Thomas H. Lee, and also from Elizabeth Teesberg. It's called the value agenda. And this was coined back then, and it's called the strategy that will fix healthcare. You can find this article on the Harvard Business Review. So you have what's called organized into integrated practice units, IPUs. So your IPUs can consist of GPs, specialist, physio, dietitian. So let's say you want to have a model around obesity. So who would be in your IPU? You could have a GP in the IPU, you have a dietitian in the IPU, you have a psychologist in the IPU, and you may have a physician or endocrinologist in your IPU around obesity. And that is the specific disease episode that this IPU would have. Number two, we then look at the measure outcomes and costs for every patient. If you were to bill fee for service, what is the average cost of billing for fee for service? Number one. Number two, if you're going to have an obesity program, what outcomes, what clinical outcomes are you looking for? Are you looking for, number one, a reduction in BMI? Are you looking for decreases of comorbidities? Are you looking for control in comorbidities? Are you looking at percentage of body fat, lean muscle, any type of clinical outcomes that you have? All right. And then number three, you would then move to bundle these payments for your care cycles. So how would you then bundle this care? into one package? And how would then you be able to integrate this care delivery across separate facilities? This is only if people are going to expand to scale. And number 5, expand excellent services across geography. Now, this is for expansion to scale. But for your average provider, 1, 2, and 3 would be some of the most important parts. And obviously, everything is underpinned by a build for enabling information technology system. In this day and age, especially in healthcare, tech is the new thing. Tech, AI, all of the big buzzwords is what improves clinical care in terms of your protocols, your clinical pathways, and just monitoring of your patients. So now we talk about obesity. We now have our IPU members. We now have the clinical outcomes that we're going to look at. We then now bundle these payments, and then we go and you would negotiate, or you'd say, for us meeting a certain percentage of our clinical outcomes, this is the pay for performance that we're looking at. How much money would we be getting? Would it be 10%, 20%? What are the incentives that we're looking at? So if you actually look at the hospital environment, you'll see that the hospital groups are actually quite a bit far ahead. In terms of claims paid out by medical aids, alternative reimbursement models is already sitting at around 10 billion rands. Per diem, which is another alternative reimbursement model, which is usually about flat rates, for your hospital days where a patient is admitted, sitting at about 6 billion. Your fixed fees, which is a standard amount of money that is paid for an admission. Common fixed fees are your normal vaginal deliveries, your cesarean sections. You'll find that you are required to have a standard length of stay for a cesarean section, maybe say it's 3 days, and the medical aid will pay out 13,000. That's it. We're done. Standard. If you go outside your 3 days, then that fixed fee falls away. And then you as the hospital groups, you are actually monitored against those fixed fees, against why do you have so many of your cesarean sections staying longer than 3 days? What is your complication rates? What are the clinical indications? So as hospital groups, we too are also measured against such quality standards. And cesarean sections is very common in terms of maternity. That's one of the easier ones. When you start going outside of your 3 days, the medical aides then notice what is happening clinically. Are you having high risk patients? Do you actually have inefficiencies? Are the doctors actually just keeping the patients for 4 and 5 days? Is it maybe social determinants of health? Does the patient have social issues, which is why they're staying for 4 and 5 days? Is it because your doctors are just discharging patients late? So these are things that hospitals are also measured against in terms of our clinical outcomes when we enter into these types of ARMs with the medical aids and the funders. And then you'll see global fees is a smaller amount where we're only now sitting at 0.91 billion. However, that will continue to grow. However, global fees tend to be slightly a bit difficult sometimes to navigate. So now let's look at some examples of what we have. This is not exhaustive. So to anyone who I may know from a previous lifetime and I have excluded you, my apologies in advance. So here's one. It's called PPO Serve, and it's called the Value Care Team. So these are multidisciplinary teams that are built around GP practices that provide integrated care for shared patients and ensure success in value-based care contracts with medical schemes. Please, everyone, go onto everyone's website and have a look at what everyone does. So this is an example of what I mentioned of these types of teams that include GPs, specialists, any type of allied healthcare provider. We would usually call this a population health value-based care program because this GP and the specialist serves a specific population. So you may have 100 patients allocated to you. So then you would get a capitation fee. and not bill fee for service. So you have a capitation fee, you have your 100 patients that you look after. And then on top of that, they also have a pay for performance based on the agreements that you would have contract with them and contract with the medical aids. Another one that we have is called Aligned. Aligned is a value-based care program that specializes in palliative care. So they are also an outpatient value-based care program, and they have a multidisciplinary team. So you'll find that all of these ones that I have on this slide all include multidisciplinary teams. So Aligned also has a multidisciplinary team where you'll have either oncologists or GPs or any type of specialist that have specialized in palliative care. They also include spiritual members on their teams, be it a chaplain, they have counselors. So they also have a very holistic approach within theirs. And they too they also bill and are assessed based on their contracts with the medical aids. You have another one, which is called ICPS, Improved Clinical Pathway Services. This is what I was talking about, where this is an arthroplasty or joint replacement. So ICPS contracts are with hospital groups, prosthesis suppliers, multidisciplinary teams made up of surgeons, anesthetists, and physiotherapists, dedicated to assisting with enhanced recovery after surgery joint replacements. ICPS includes your inpatient surgery with your joint, and you have a set amount of physiotherapy visits outside post-discharge. One of the things I do know for their clinical outcomes that they look at is joint revisions and readmission rates. And then you have what's called DBC. DBC is actually a provider within the chronic neck and back program or chronic back and neck program. I'm sure many of you would have heard about that. That is a program that is across many of the medical aids from Bonitas to Fed Health. I'm not too sure about Discovery. And all of these are underpinned by clinical outcomes and care coordination, right? So DBC is an active spine and shoulder treatment system used for treatment of long-term back, neck, and shoulder problems. However, I do know in the medical aid sphere, DBC, in terms of a value-based care program, is mainly for long-term back and neck pain. So all of them underpinned by clinical outcomes and care coordination. And what is care coordination? And care coordination is very important. And many GPs will know about care coordination. And these days, members have to nominate their GP. And that GP is seen as your gateway into the healthcare system, and they will coordinate your care. They will then refer you on to whatever specialist when you need escalation of care. And this is actually shown to give improved clinical outcomes. And it is also shown that specialists are now treating the right patients at the right time at the specialist levels. So you don't have pediatricians going and treating children with snotty noses. You have pediatricians who are treating patients for what they went to school for. You have surgeons treating patients for what they went to school for. And all that primary health care is then done and taken care of at a care coordination level. So let me just tell you some of the outcomes that I did find on the internet. I took this from the South African Health Journal of 2024. And this is an article from Dr. Gola, who is at GEMS. It says, for the PPO SERV, which they implemented, throughout the pilot, a predetermined aggregate score that measured surrogate outcomes, such as risk-adjusted admission rates, cost per admission, readmission rates for chronic disease management, such as HIV, cardiovascular disease, and asthma, showed a 30% increase in performance. So basically, there was massive improvements in readmission rates, cost per admissions, and just chronic disease management. DBC model, once again, which implemented 5 of the 6 value agenda elements, resulted in a 32% reduction in spinal surgery, 8.5 reduction in readmission rates for medical back and neck pain management, 68% improvement in enrolled patients' range of movement, 93% reduction in reliance on pain medication, 93% of the enrolled beneficiaries were satisfied with the service they received, and 98% indicating that they would recommend the program to others. I must say, I have tried this program. Absolutely amazing. This is just a short list of my references that I have for this evening. And I just want to say thank you. I do know it's been a short talk, but I thought it was just very important, especially for the last webinar of the year, just to bring a very important topic in terms of where private healthcare is going, especially going into the future and also in preparation for NHI. I just want to thank everyone. Thank you.
Thank you very much, Dr. Mahlangu, for a truly enlightening presentation. Health economics, I must say, is a topic that was really not included at medical school, and we know very little about. Just one question I have. Given the current healthcare landscape, what key steps would you recommend healthcare workers, especially those in private practice, to take to effectively prepare for the implementation of NHI?
Number one is people need to be open-minded. The current way of work is actually not sustainable for all of us, including hospital groups. And we need to start thinking of ways to better service the communities that we work in, and every time people say cost saving, we always think that we're taking money out of our pockets. And what I was trying to show today is it's not necessarily money will be taken out of your pocket. You may actually find that you'll earn the same amount, if not more. And I think it's very important for everyone to know where we're going, and make it very important to be, number one, open-minded, interrogate a lot of the models that are out there, think outside the box, band together, all of you here, because the Health Professions Council has allowed now for MDTs to be there. And it's very, very important that we not be so resistant to change, seeing the pace that government is moving towards NHI. And I think for me, my biggest fear is that as hospital groups, we're already above the curve. And you'll find that a lot of the providers are still behind, and they may be kept wanting and on the back foot.
Thank you very much. And your opinion on group practices versus solo practices? And, I think you did touch on the multidisciplinary teams in managing patients. Your take on that?
When I was a GP, it's actually not that easy being a solo practice. You can get so much more out of having an MDT, and it broadens the work that you can do. I mean, something very simple that has actually been around for a very long time is CDE for diabetes treatment. That would be a GP and a nurse that you have in your practice. And by having that, you actually develop clinical efficiencies. Doctors are now also starting to have clinical associates in their practices because they're starting to see the benefits of working together with the dietitian, with the GP, with the specialist, and also being able to do more. And I think I kept saying this, and it allows everybody to practice at their level. Um, and it's so ironic is that mental health, the psychiatrists have gotten this right. If you are admitted in a wellness facility, every day, if not every week, there's an MDT meeting about the patients. It includes the psychiatrists, the psychologists, the OTs, the dietitians, and everyone involved in your care when you are admitted. And we tend to forget that when we go outside in outpatient settings, that the same thing works in hospital as it would do out of hospital.
Thank you for that. There is a question in the chat. May I also just encourage the participants to please post your questions in the chat. There's a question by Mohuden Khan. It also relates to NHI. He says, are we ready for NHI? There's something blocking my view here. Are we ready for NHI? What are the major challenges, especially in rural areas?
Muhaddin always likes the tricky questions. Are we ready? If NHI was implemented today or tomorrow, I think honestly a lot of us would not be ready. However, everyone, I do know, especially in the hospital group arena, people are moving very fast to become ready in terms of private-public partnerships, global fees, alternative reimbursement models. The rural areas is a very unique challenge because we also tend to forget that even in private, there is poor access to healthcare in the rural areas. And it would have to be unique solutions that we implement in the rural areas. There is no cut and paste. I believe that you cannot take what happens in an urban area and implement it in the rural areas because they have a very specific demographic, disease burden, and healthcare ecosystem out there. So it would take a lot of innovation, which we already have. Use of telemedicine is going to be very important in terms of NHI in the rural areas. Use of tech, apps, electronic healthcare records, and the leveraging of AI and, as we always say, big data and machine learning will become very vital in the rural areas.
Interesting. There's another question in the chat. It's Linda, who says, please talk about the Unjani nurse practitioners and why are doctors' assistants not allowed to open their own practice?
Okay.
Or doctors' assistants, okay.
Great.
Why doctors' assistants are not allowed to open their own practices?
So I don't know much about the Unjani nurse practitioners. However, doctor's assistants would be clinical associates. And right now, the legislation has that a clinical associate must still work under the supervision of a doctor. And that is the current legislation. So you'll find that a lot of doctors have now started employing clinical associates, whether it be to assist them in their ward rounds, in their rooms. You may also bump into clinical associates in the hospitals. Sometimes we use them to assist the doctors in the hospitals You may find clinical associates in certain hospital groups. They may have them in casualty to assist the doctors that are on call also. So, yeah, so their use is becoming more and more widespread. But however, at this current time, legally, they cannot open their own practices.
Yeah, thank you very much. I think the question we have here in the chat by Lydia will probably be answered by our team, IT team in Clinix, and not yet. It's Lydia Forum says not yet seen previous 5 CPD points on HPCSA list.
Okay, yeah.
I think our team will be able to answer that one. Perhaps if you contact them, would you recommend that they contact them directly?
Yes, yes, you can just contact the normal email address, and they will follow up with Sama.
Okay. Right. Okay. Yeah, I see Linda again. Just a comment that she's making says, yes, clinical associates, I meant, but nurse practitioners are mushrooming everywhere. So I guess Linda is trying to say clinical associates are not allowed to open their own practices, but nurse practitioners are mushrooming everywhere, she says. So that's an interesting one.
Yes, yes, they are. So if I put on my hat from a previous lifetime in medical aids, nurse practitioners were mushrooming. They've been opening their own clinics. They are opening their own private practices, and they are going full force into private healthcare. They are dispensing, apologies, they're dispensing and writing scripts in line with their scope of practices. They are setting up well baby clinics, pap smears, the usual preventative care measures. Some nurses who are advanced midwives are even setting up their own birthing units where they have a obstetrics and gynae attached to that unit for any complications, and also the transferring of patients to hospital. So a lot of the nurses have really mushroomed and hit the ground running.
Yeah. Yeah, I guess the issue of clinical associates would probably will get an answer from HPCSA, I guess. One other question from and it's actually not a question, but a comment. Ellen Sokwai says, I've heard presentations from solely private as well as public role players, and I must say both have painted a very gloomy picture, re-NHI implementation. This, however, is so refreshing and encouraging. I see the light. Thank you so much. Okay. So, yeah. And then Cora. And
Thank you,
Cora,
Ellen.
yeah, Cora saying, even at OT, assistants cannot work without OT. I take it that you mentioned operating theater or OT or occupational therapy, I guess.
Yes, occupational therapist.
No, I'm a surgeon. I'm thinking operating theater. Okay. Okay, so all right, Zainu is asking for an email address. Perhaps Zainu, I'm not sure which email address you wanted, but the Clinix one, you just check the email address when, just how you receive the invitation for this presentation. That's the email address we're referring to. Oh, okay. I think you have been answered. There is an email address. Then there is Mahale. mentioning that suggestions are very good. Service providers, including hospitals, will fight for the fee for service beyond the Constitutional Court, even if, so I've just lost that. Okay. Even if they had to approach the devil, they will. Listed entities, big pharma, service providers need to make a killing. They are now fighting NHI to protect minority privileges and a few assimilated Blacks. So that is Mahlangu, who's making a comment. Would you like to respond to that?
Yes, I actually want to respond to Mahlangu. Let's see if I can. All right. So let me start here, Mahlangu. So the reason why I showed this slide is these are claims that are actually already paid. So this is what's currently being paid. This is reimbursement methods for hospital services in 2022 to 2023. This has been issued by the CMS Industry Report of 2023. So you can actually go on the website for CMS. And this is what all medical aid schemes, all 71 schemes in the entire country, have already paid for hospital groups, which is other alternative reimbursement models. You're looking at 10 billion Rand in 1 year have already been paid out to hospital groups for alternative reimbursement models that I have presented on. Per diem. Per diem is actually what we call decreasing or decaying per diem. So you'll find that on day 1, I am paid 5,600 Rand. By day 3, I'm paid 4,300. By day 7, I'm now being paid 2,500 as a hospital group. It serves me no purpose for me to keep you in the hospital longer and for me to be on fee for service. Medical aids have already started moving a lot of the hospital groups to per diem, which is why you see it's even increasing up to 6.3 billion. So the point is for us as hospitals and facilities is to ensure that the doctors that are in our facilities treat patients at the lowest cost with the best clinical outcomes. And that would then save me from a per diem because I gain nothing for a patient sitting in the hospital for a per diem on day 7. It's the same with a cesarean section. If a cesarean section, I get paid a fixed fee of 13,000 for a patient in the hospital. The patient sitting there on day 4 and 5, I gain absolutely nothing for that. I've actually lost money. And you can see on fixed fees alone, already 4.14 billion has been paid. So these are actually not suggestions. These are things that are happening now in the industry, which is why I thought I would present this to show people this is what is currently happening, and also to ensure that providers are not left behind. Hospitals have been implementing these type of arrangements with the funders, and doctors, allied healthcare professionals, everyone else is slowly being left behind. And then if you look at global fees, which I mentioned that one of the most common global fees is bariatric surgery, which on average, if I remember correctly, you get about just under 200,000 Rand for the entire episode, right? I gain nothing as a facility for keeping you in the hospital longer. In fact, I want you to stay for just the amount of money that I'm paid for. Your doctors that operate on you in bariatric surgery will also have to manage that 200,000 Rand. That's all we get, 200,000 Rand. If the patient is uncomplicated, I gain nothing on a fee for service. So these are the type of models that funders are also actively moving all of us towards. And you also see that specialists themselves are starting to go in these routes in terms of what the funders want us to pay for. I mean, how they want to reimburse. PPO Serve is currently in place in Pretoria North, and also in Outreachville, and it has extended out into certain areas of Gauteng. You also have certain areas in KZN that are on the PPO SERVE program, which is the value care team. They are currently contracted to GEMS. You have Aligned, which is for palliative care. That is paid for by Polmed, Bonitas, GEMS, Fed Health, and quite a number of medical aid schemes where you already have people who are contracted to this. These are models that exist and that are being paid for and funded for. You then have ICPS. That's a model that's actually been around for years. They first started with discovery medical aid. And this is for your joint replacements, for arthroplasty, for a knee replacement, for hip replacement, where it is one huge bundled fee of maybe about 180,000 Rand. And that includes your doctor's fees, your anesthetist fees, your hospital admission, and the joint itself, and the physiotherapist, including the physiotherapies post-op, because they are also paid as per their clinical outcomes. The chronic back and neck program, I mean, that has predated a lot of us and has been in existence for quite a while. So these are things that are actually existing. Fee for service is unsustainable currently. And that is something a lot of people in private healthcare will admit. It's unsustainable. One medical aid on one option is doing a 38.2% increase on contributions. So where will all of us get our income from in terms of the medical aids? The fight for NHI is actually the way it's going to be implemented. NHI is a funding model for universal healthcare. Everyone is for universal. I'm for universal healthcare. A lot of us are for universal healthcare. I think the bone of contention is the funding model and how the government intends to implement universal healthcare, which I will not give my personal opinion on today. Thank you.
Thank you very much for that. Dr. Mjakaji, I see you have raised your hand. Would you like to, can he be unmuted? Dr. Mjakaji? Yes, you can.
Thank you very much to all of you on this wonderful presentation. Thank you very, very much. There are two things that I thought I would share. The first thing is that the Orthopedic Association in South Africa has decided to set up what is called an orthopedic registry, where virtually all operations being performed by orthopedic surgeons can be placed on a database controlled by the Surgeons Association. And that is to serve the purpose of developing empirical evidence of what constitutes standard care. So there is the issue of 180,000 for arthroplasty. Is that a real figure? We are only finding out now that it isn't quite a real figure, but that's not the point. No. I'm saying that is what the medical aids were proposing.
Oh, okay.
But as a consequence of data gathered from the registry, and that is surgeons countrywide in different settings doing the same procedure, what constitutes standard care? And therefore, we can then come up with empirical numbers that make sense.
Yes.
To those who want to look at that. What we are finding is that there's pushback from the funders. The pushback from the funders is because we control the registry. Therefore, we control the flow of information. And the funders are not happy with that, because when we negotiate empirical pricing modules, we are in a position of strength, not in a position of weakness. And therefore, they cannot come and make us an offer of 180,000 when the real figure is 250,000. Right? That's the first thing. The second thing is to say I started medicine, my first day in 1984, 40 years ago. Every single day of my life since 1984, I have been told that private medicine is unsustainable. That is a wholesale lie. It is just not true. If anything, government-funded healthcare is unsustainable. I just wanted to share. Thanks.
Thank you very much, Dr. Mujakashi. Okay, any comment, Dr. Mahlangu?
No,
Oh.
none from me. I do
Oh.
know that that certain societies have started. Disclaimer, doc. I'm I'm not from the medical aid.
Oh.
Um, that
Yeah.
certain societies have started setting up their own registries. One of the recommendations from the HMI was for registries to be set up. I believe there is a urology registry that has been set up as well. And because of this is the only way for us to get, evidence-based data, empirical data that allows for everyone to see what exactly is the standard of care. Legislation will tell you that it's what happens in state. Then you'll find that the funders will say, no, this is only what we're going to pay for. Yet, however, standard of care has moved on past a lot of the legislation in terms of your PMPs, which is just a huge fight between providers, hospital groups, and the funders. So definitely in terms of the registries, the clinical data, this is things that will set up and ensure that, there's better clinical outcomes and there is better equity in terms of what happens in our industry.
Thank you so much. Yeah, I do not see any more questions, any more questions in the chat. And it's now 7:02, and we have had 242 participants. Please allow me to thank you again, Dr. Mahlangu, for a truly enlightening presentation. And to everyone in attendance, I hope you have lessons taken and lessons learned here, that we can all reflect on them and we can apply them in our respective roles. Together, we have the opportunity to shape a future where healthcare is equitable and sustainable for all. So on that note, and on behalf of Clinix Health Group, thank you all for joining us today. Let us continue to strive for excellence and innovation in everything we do. Wishing you all of the best this festive season. Be safe and have a great evening. Thank you very much.
Thank you.